Hello, everyone. This is Rebekah. We will get started in just about 1 to 2 minutes, depending on when it stops looking like people are rapidly entering the room. We're just going to give it another like 30 seconds because the numbers are still rapidly going up. Okay, let's get started. Hello, everyone. Welcome to our co-hosted webinar between NACCHO, NASTAD, and NCSD. We're really excited to share this webinar on STI testing. We're going to be talking about new point of care advances and why this is helpful for the local public health or public health in general across the country. My name is Rebekah Horowitz, and I'm at NACCHO, and so I'm just going to kick us off. Our agenda for the day, we're already in the welcome. I will talk briefly about rising rates of STIs. I will turn it over to Dr. Schoolnik, who will talk about traditional STI testing methods and challenges, benefits presented by point of care testing, the impact on health department services and care with point of care testing, and then we'll have some time for Q&A. Again, our speakers today, I'm Rebekah Horowitz. I'm with the National Association of County and City Health Officials. We have Gary Schoolnik, Chief Medical Officer for Visby Medical, as well as a Professor of Medicine at Stanford University, and Jennifer Mann, who's at the National Coalition for STD Directors. We will also have Angela Johnson with NASTAD, who will be moderating the Q&A. So as questions come up, please put them into the Q&A box. Angela, as well as her colleague Krupa, will be keeping an eye on that so that we can move through those Q&A questions quickly at the end. So I'm just going to do some setting of the stage, some level setting. So prevention and control of STIs is generally based on 5 major strategies. Those strategies include accurate risk assessment and education and counseling of persons at risk, pre-exposure vaccination for vaccine preventable STIs, identification of asymptomatically infected persons and persons with that should say symptoms, not systems, effective diagnosis, treatment, counseling, and follow-up for infected persons, and evaluation, treatment, and counseling of sex partners of persons who are infected with an STI. So when we think about all of these major strategies, there's a lot that can happen between the time that someone goes into the clinic to get tested and when they actually get their results that would impact their ability to participate in these strategies. And so that's really why we wanted to talk about these new developments in point of care testing and how they would impact the ability to speed up some of these strategies or the use of some of these strategies. So rising rates of reportable STIs. this is probably familiar to many on the webinar, but in 2019, the CDC surveillance data showed us that 1.8 million cases of chlamydia were reported to the CDC, making it the most common notifiable condition in the United States in 2019. That corresponds with a rate of 552.8 cases per 100,000 in the population, or an increase of 2.8% from 2018. Those rates also increased among males and females in all regions of the United States and among all racial and ethnic groups. Similarly, for gonorrhea, there was an increase. We had over 600,000 cases of gonorrhea reported, making it the second most common notifiable condition in the United States. There, the rates have increased 92% since their historic low in 2009. And overall, the rate increased 5.7% from 2018. Rates increase among males and females in all regions and among all racial and ethnic groups. And again, this was the 6th consecutive year of record-breaking STD cases for those reportable STDs that CDC puts out in the STD surveillance report. So for disparities in reportable STDs, in 2019, over half, 55.4% of reported cases of STDs reported to CDC were among adolescents and young adults aged 15 to 24. And 30.6% of all cases of chlamydia, gonorrhea, I'm guessing that's 36. Whew, this is troublesome. Sorry about that mistake. Of all cases of chlamydia, gonorrhea, and syphilis, 36, yes. 36% of all cases of chlamydia, gonorrhea, and syphilis were among non-Hispanic Blacks, even though they represent only about 12.5% of the population. MSM, or men who have sex with men, were also disproportionately impacted. We also wanted to talk about trick. So trick is not a condition that is required to be reported to the CDC. And as a result, it is likely both underdiagnosed and of course underreported. CDC recommends testing for trick in all women or all people having vaginas seeking treatment for vaginal discharge. And 70 to 85% of trick occurs as asymptomatic in women. So CDC is recommending that you test for trick only when there are symptoms, but 70 to 85% of trick occurs without symptoms. Just one more piece of evidence on why it would be underdiagnosed and underreported. And trick increases the risk of contracting HIV by 2 to 3%. So if you look at this chart here for estimates for prevalence and incidence in 2018, you see that the estimates are that trick is actually there are more incidents of trick occurring than chlamydia or gonorrhea, even though those are our most reported notifiable diseases. So I'm going to turn it over here to Dr. Schoolnik to talk about traditional STI testing and the challenges that it presents, and then point of care testing.
Thank you very much, Rebekah, for that excellent summary of the current epidemiology of these STIs. May I have the first slide, please? I'm going to be speaking about the impact of point-of-care diagnostics at affecting the undertreatment rates and overtreatment rates for STDs. In this first part of the presentation, I'd like to present a case to you. Could you please turn to the next slide? This is the case of Mrs. Smith, who presents to the county sexual health clinic. Her chief complaint was increase in her vaginal discharge of 10 days duration, and most prominently, concern about having a new sexual partner in a relationship that began 2 weeks before. Her past medical history is significant for a positive HPV DNA test 1 year ago, 1 episode of bacterial vaginosis 8 months ago, 3 episodes of urinary tract infections during the past 3 years. And on her annual screening test last administered 11 months ago, she tested negative for the gonococcus, chlamydia, syphilis, and HIV. And as we go through this talk, I'll be using NG to signify Neisseria gonorrhoeae and CT for chlamydia trachomatis, and TV for trichomonas vaginalis. Her clinical course was as follows: the triage nurse at the clinic focusing on Mrs. Smith's concern about a new sexual partner, had the patient collect a vaginal swab. The swab was sent to a central lab, and then a complete medical history and pelvic exam was performed. Next slide, please. Here is the journey that vaginal swab sample took. It was collected on day 1, as you can see on the left. It reached the central lab within about 18 hours. A result was obtained by the central lab on day 3, 72 hours after Mrs. Smith presented to this clinic. There were 3 attempts to contact the patient. On the 3rd attempt, it was successful, and the patient returned to the clinic and was treated on day 7. So if we look up that vaginal swab sample, the sample to result at the central lab took 72 hours. The sample to treatment, which is what really matters, of course, took 168 hours. May we have the next slide, please? The physician, upon seeing Mrs. Smith and hearing her history and conducting the pelvic exam, elected not to treat her due to the absence of compelling symptoms or physical exam signs. 72 hours later, the central lab reported that they had detected the gonococcus. This, therefore, is an example of either undertreatment or, more specifically in this case, delayed treatment. Next slide, please. So let's review this once again in the context of that delayed treatment. So as you can see on the red arrow on the left, Mrs. Smith had this vaginal swab collection on day 1. The result was obtained on day 3, was positive for the gonococcus. And then she only returned to clinic and had the correct treatment, intramuscular ceftriaxone, on day 7. So there was a 7-day delay in treatment in this case. Next slide, please. What are the consequences of undertreatment or delayed treatment of an STD? Well, I'd like to review them with you here. First consequence, onward transmission of an STD pathogen and thus propagation of the epidemic if the individual continues to have sexual relations. Delayed treatment results in the possibility that there will be complications of progressive infection, particularly in the case of the gonococcus and of chlamydia. It is possible in that 7-day period the organism could proceed from the endocervical canal onto the endometrial surface and into the fallopian tubes, resulting in pelvic inflammatory disease, with the well-known complications of that being infertility, ectopic pregnancy, and chronic pelvic pain. Obviously, there's a delay in the expedited partner treatment that could have occurred more quickly had the result returned more quickly. There's a reduced opportunity for what I call result-enabled face-to-face clinician-patient dialogue. Inefficient clinic workflow also would result because the staff needs to contact the patient by phone, and that's often problematic, as you all know, and schedule for a return appointment. There's reduced patient satisfaction because the patient leaves the clinic on the initial clinic visit without a precise diagnosis. And there's obviously reduced clinician satisfaction because the clinician does not have a result that drives a result-specific kind of intervention. Next slide, please. Scenario B, which is the same patient, Mrs. Smith, but in this case, an example of overtreatment of an STD. Here, the clinician elects to treat before lab results are provided for the vaginitis syndrome because the patient complained of a slight discharge in her normal vaginal discharge. Based on that assumption, the patient received metronidazole orally for 7 days for treatment of possible bacterial vaginosis and trichomonas vaginalis. 72 hours later, the central lab reported that the testing they did was negative for the gonococcus, negative for chlamydia, negative for trichomonas, and negative for bacterial vaginosis. Thus, this would have been an example of overtreatment of an STD since the patient received metronidazole based on an empiric view by the clinician that she had either bacterial vaginalis or trichomonas. Next slide, please. What are the consequences of overtreatment of an STD? Well, of course, there's unnecessary exposure of the patient to a medication leading to possible adverse effects. As you all know, metronidazole sometimes is associated with dysphoria and nausea and many other very unpleasant symptoms on the part of patients. There is the possibility of selection of antibiotic-resistant microorganisms, thus contributing to the further emergence of antibiotic-resistant infections. Thus, this is concern that grows out of the antibiotic stewardship program. There's ineffective or misleading clinician-patient dialogue because the discussion with the patient on the initial clinic visit will be biased by an incorrect diagnosis. For example, the doctor would have discussed the vaginitis syndrome with this patient and not, for example, any other process that may have in fact been present. There's inefficient clinic workflow because the staff needs to contact the patient by phone, which is, as you all know, is often difficult, and schedule a return appointment for the correct treatment. And then there's reduced patient satisfaction and reduced clinician satisfaction as well, since clinicians feel uncomfortable when they prescribe therapy solely based on an empiric notion of what might be wrong rather than what is actually wrong. Next slide, please. What are the rates of over and under treatment for chlamydia and the gonococcus? And I think you'll find that the data presented here from 6 studies is actually quite stunning. And I want you to focus on the column where, which is third from the left and second from the left, where in the third from the left column, it's empiric treatment for chlamydia and the gonococcus, where eventually the laboratory results are negative for those 2 pathogens. This is the percent of patients overtreated in these clinical settings. And the clinical settings reported here are emergency room departments in inner city hospitals in most cases, an urgent care center in Baton Rouge, Louisiana, and so on. These are different regions of the United States, different patient populations, but nonetheless, the percent of overtreatment and undertreatment are significant in all cases. So they range, overtreatment ranges from a low of 16% to a high of 86%. Can you believe it? As high as 86 or 87% of patients presenting to one urgent care center or an emergency room were actually overtreated on the assumption that they had an STD, in this case, chlamydia or the gonococcus, which in fact they did not have, based on a quality test that was performed but was delayed in its results. Let's look at the percent of patients undertreated. In these cases, the patients really did have chlamydia or the gonococcus, but they were not treated at the time they were seen in the emergency room or urgent care center. Well, the undertreatment rate ranged from a low of 4%, but if you really look through these studies, the high is 86%. There were 2 institutions where the undertreatment rate for chlamydia and for the gonococcus was 43% and 43% in yet another case. So I think in summary, you can see when you use empiric notions of what might be wrong in prescribed therapy or decline to prescribe therapy, you get and can expect exceedingly high percents of overtreatment and undertreatment. Next slide, please. Let's look at another consequence of delayed diagnosis, which is the patient who's lost the follow-up. Next slide, please. So once again, we return to Mrs. Smith, and to a third kind of treatment decision. In this case, the clinician elected not to treat due to the absence of compelling symptoms or physical exam signs. 72 hours later, the central lab recorded detection of the gonococcus. But then, despite multiple calls by clinic staff and by a county public health worker, the patient could not be contacted. This is an example of a patient who's lost to care. Next slide, please. What are the consequences of an STD positive patient who is lost to care? In many respects, it's rather similar to the consequences of an STD positive patient who has experienced delayed care, that is, onward transmission of an STD pathogen, delayed treatment resulting in complications, leading in the case of the gonococcus and chlamydia potentially to pelvic inflammatory disease, no opportunity to proceed with expedited partner treatment, no opportunity for a result-enabled face-to-face clinician-patient dialogue, inefficient clinic workflow because of fruitless attempts by clinic staff to contact the patient by phone to schedule a return appointment for treatment, and of course, healthcare provider discontent, stress, and apprehension that the patient remains untreated and may develop complications of their infection. Next slide, please. What are the rates of patients lost for follow-up? And I'm just going to summarize the rates for patients lost to follow-up in two settings. One is the emergency department. So in one study, 40% of adolescent females presenting to the emergency department in Grand Rapids, Michigan, were lost to follow-up. In a second study, 40% of young women were lost to care after the initial emergency room visit in Cincinnati, Ohio. And yet a third study, 8% of patients positive for chlamydia or gonococcus were lost to care in an urban emergency room setting in Philadelphia. Turning to a different setting, this is the patients lost for follow-up in STD or family planning clinics. So in a first study, 26% of patients tested in an STD clinic in Virginia were lost to follow-up. In a second study, 18% of patients presenting to an STD clinic in Washington, D.C. were lost to follow-up. Next slide, please. So we've considered overtreatment rates, undertreatment rates, and patients lost to follow-up, all of which flow in a significant way from delayed testing, that is, patients who are tested, but then where the test result does not come back for several days, and therefore these consequences ensue. Next slide, please. So we're going to consider the benefits now of rapid, accurate STD point-of-care diagnostics and how they can transform patient care, and as a consequence, reduce overtreatment rates, undertreatment rates, and patients lost to follow-up. And by point-of-care diagnostics that are rapid and accurate, here's what I mean. First of all, by rapid, I mean they return a result during the initial clinic visit and within 30 minutes of receiving the sample. So what do I mean by accurate? I mean that they are PCR level accurate and their accuracy is equal to that achieved by large central lab PCR instruments. By point of care, what I mean is that these tests take place in a near patient setting, in the clinic where the patient is seen, potentially even in the examining room where the patient is seen. Next slide, please. So let's compare what it means to have central lab testing, which you're already familiar with. This is in the upper panel shown in orange, and but then consider the difference in the lower panel in a point of care setting where the results are indicated in green. So Mrs. Smith's vaginal swab would be collected on day 1. In a point of care setting using a rapid and accurate point of care device, a result would have been generated 28 minutes after the patient presented to that clinic. And in this case, would have shown that the patient was positive for the gonococcus. 35 minutes after the patient presented to the clinic on day one, the clinician would be aware of the result and would be engaged in an effective clinician-patient dialogue, discussing the result, discussing how STDs are transmitted, the complications that may ensue, potential changes in sexual behavior that would reduce the risk for STDs, and what kind of what kind of therapy would be administered. 42 minutes after presentation on day one, that patient would have received intramuscular ceftriaxone for the gonococcal result that was received just a few minutes before, and expedited partner therapy would have been initiated, all on day one, all within 45 minutes of that patient walking into the clinic. Next slide, please. So let's consider a scenario now, again, Mrs. Smith, but in the setting of a rapid, accurate point of care diagnostic. So here the treatment decision, the clinician followed the CDC treatment guidelines. Ceftriaxone was administered as instructed by those guidelines. The patient was treated 42 minutes after they entered the clinic. Correct and prompt treatment was enabled by this point of care test. There was no loss to follow-up. There was a specific clinician-patient educational dialogue, and there was expedited partner treatment that was initiated. Next slide, please. What are the advantages of a rapid, accurate STD point of care test that can prevent overtreatment, undertreatment, delayed treatment, and reduce patient follow-up? Well, the first advantage is that it enables results-driven, effective treatment within the span of a single clinic visit. Second, it reduces the probability that an untreated infection with the gonococcus chlamydia will progress into the fallopian tubes. Third, it reduces the probability of ongoing transmission of the pathogen. Fourth, it enables the prompt treatment of the diagnosed person's sexual partner via the CDC-sanctioned expedited partner treatment program. Next, it enables what I call the teachable moment, where the clinician and the patient can discuss the meaning of that diagnosis, how it's treated, and how to avoid future sexually transmitted diseases. Next, it clearly increases, as you'll see in a few moments, patient satisfaction by providing the patient with an accurate diagnosis and effective treatment. It increases physician satisfaction by providing the clinician with an accurate diagnosis. And it expedites the test and treat paradigm. It improves clinic workflow. It increases the efficiency of clinic staff and likely positively affects the clinic's cost effectiveness. Next slide, please. So I wanted to tell you about one such rapid, accurate point of care device and direct you to a publication in the Lancet Infectious Diseases that looks at a clinical trial that enrolled approximately 2,000 patients and which led to the FDA approval of this device for CLIA wave settings, point of care, as well as for large laboratories should they choose to use it in that setting as well. The summary of this study was the timely detection and treatment are important for the control of chlamydia, gonococcus, and trichomonas. Those are the three organisms that were detected on this point of care PCR device. So three organisms, chlamydia, gonococcus, trichomonas. And the objective of this study was to measure the performance of this device is produced by Visby Medical, the performance of the Visby Medical sexual health test as a single-use point of care instrument-free PCR device. It was led by Sheldon Morris. Jeffrey Klausner, who many of you know was the senior author The other authors on this study, none of whom are Visby employees, participated as PIs in this clinical trial. Next slide, please. The clinical performance of this Visby medical point-of-care device for the 3 pathogens it detects in terms of positive percent agreement, PPA, and negative percent agreement, NPA, are shown here as compared to 3 large FDA-approved laboratory instruments in central labs that use nucleic acid amplification techniques. So you can see that the PPA and the NPA are excellent, basically 98% to 99%, essentially equivalent to the performance from large laboratory instrument. And yet this device is instrument-free, single-use, point of care, and delivers a result in 28 minutes. Next slide, please. This device was also used to study its impact on overtreatment rates, undertreatment rates. And I wanted to briefly review that study, which is now in press in the journal Sexually Transmitted Diseases. This is entitled Clinical Integration of a Highly Accurate PCR Point of Care Test Can Inform Immediate Treatment Decisions for Chlamydia, Gonorrhea, and Trichomonas. Next slide, please. The outcomes of this study came from an urgent care center to see how this device affects time to treatment, accuracy of treatment, clinician satisfaction, patient satisfaction, and how this point of care device can be implemented in a clinic setting. Next slide, please. I'm just going to summarize the results because this is now in press in Sexually Transmitted Diseases in the December edition. You all can go to it and read it, the results for yourself. But in terms of the survey of clinician satisfaction, the clinicians agreed that the test and treat model enabled by this device provides value specifically to the question, I would prefer test results right away versus waiting for several days. Strongly agree by the clinicians who participated. I am an advocate of antibiotic stewardship, which this device enables. Strongly agree. I would find value in discussing the results of the test right away with my patients. Strongly agree. Next slide, please. Here's the patient survey. There is value. The patients concluded there is value in same-day testing. To the question, I would prefer to find out results right away versus waiting for several days. Strongly agree. To the result, if I needed treatment, I would prefer to get it the same day as my visit. Strongly agree. And to the question, I would prefer not to take medication if I don't need to. Strongly agree. Next slide, please. To the questions that looked at the ease of use of a self-collected vaginal swab, the conclusion by the patients was self-collected vaginal swabs are easy to use. To the question, the vaginal specimen collection kit was easy to use, agree, strongly agree. To the question, I felt confident using the vaginal specimen collection kit, strongly agree. To the question, I would need support of a clinician nurse to be able to use the vaginal specimen collection kit, disagree, meaning they feel they could do it independently without direct supervision by a healthcare provider. Next slide, please. I'll just briefly summarize that the overtreatment and undertreatment rates based on the central laboratory instrument were the same for the chlamydia, gonococcus, and trichomonas as shown in the earlier summary. Namely, 82% of patients were overtreated for chlamydia, 91% overtreated for the gonococcus when they relied on a delayed central lab result, and nearly 90% of trichomonas patients were overtreated as well. The undertreatment rates are shown here as well. In summary, if treatment was based instead on the immediate result provided by the Visby device, 33 of 33 cases of overtreatment could have been prevented, and 13 of 15 cases of undertreatment could have been prevented. Next slide, please. What about rapid point of care tests and how to optimize their use in clinic workflow. Next slide, please. So this is just a suggestion for how to integrate a rapid point of care test such as the Visby medical device into a patient workflow in a typical, for example, STD clinic. The patient walks in, the patient's chief complaint is identified. And if the patient's chief complaint includes, for example, lower abdominal tenderness or pain, increased vaginal discharge, abnormal vaginal bleeding, a risky sexual partner, a partner who has an STI, painful urination, increased frequency or bleeding after intercourse, then a self-collected vaginal swab is obtained, usually in a laboratory in the triage area. And we have found that patients can do this with confidence and do it quite easily and accurately. Then that swab sample is immediately inserted into the Visby medical device. The device is run, and during the 28 minutes it's run, the patient then has a more thorough history taken and the patient is examined, usually a pelvic exam. And then 28 minutes later, the result of the Visby medical device becomes available, and specific intervention that's result driven then occurs together with effective patient education so that treatment occurs on the same clinic visit. Next slide, please. So I want to summarize the main points that I've made today. First, nucleic acid amplification point of care test has been developed and FDA approved that detects 3 important STD pathogens, the gonococcus, chlamydia, and trichomonas. Clinical trials have demonstrated that this device is as accurate as large laboratory instruments in centralized labs. Next, this FDA approved STD point of care test can provide a result in less than 30 minutes. And thus enables a patient to be accurately diagnosed and correctly treated within the span of a single clinic visit. In addition, it is easy to use by non-technical staff, requires less than 1 minute of hands-on time, and the results are easily interpreted. Its use will reduce the likelihood that a patient will be overtreated, undertreated, experience delayed treatment, or be lost to follow-up. This point of care test can be easily deployed to a variety of clinic settings, including urgent care clinics, ERs, student health centers, STD clinics, and even mobile vans, and eventually it could even be used at home. By providing an accurate result during the span of a single clinic visit, its use will increase patient and clinician satisfaction, enable the teachable moment between clinician and patient, increase clinic efficiency, and improve clinic cost effectiveness. Future STD point of care tests will not only detect the pathogen, but also simultaneously identify effective antibiotics for that pathogen, thus ushering in the era of personalized medicine for infectious diseases. And finally, use of these devices will play an important role in the control of what I call the other epidemic, which is the ongoing epidemic of STDs, which despite the current epidemic of COVID, we know the STD epidemic is a public health crisis that places at risk the health of all. Thank you very, very much for your attention to this lecture, and I certainly invite your questions.
Thank you so much for that. So good afternoon, everyone. I do encourage you to continue asking your questions in the Q&A box. I saw some in the chat. Make sure you get those in the Q&A box. We'll be sure to answer them at the end of the webinar today. But good afternoon. My name is Jenny Mann. I'm from NCSD, and I will present today on health department perspectives on point of care testing. I will be summarizing some work out of Anne Rampalo's shop at Johns Hopkins University in Baltimore, some research that was conducted earlier this year. Next slide, please. So what did we already know about point of care testing in health departments? Well, we know that they're expensive. We know that the rapid results, ease of use, and non-invasiveness, as well as high validity and reliability, are key considerations for use. So if we can really derive some value out of them, and we can fit them into a busy sexual health clinic, we know that they're of very high value as long as we can trust the results. But there was a significant gap, and there continues to be, in our understanding of the perspectives of key stakeholders in the decision-making processes surrounding the adoption of point-of-care tests. So Dr. Ann Rapallo decided to conduct some focus groups around the country with health department staff, including providers, administrators, nurses, et cetera, to really understand some broader themes in terms of considerations for point-of-care STI testing in sexual health clinics in public health settings. Next slide, please. So in early 2021, we assisted in recruiting 27 participants for in-depth interviews. We conducted 2 focus group sessions with medical and allied health professionals on their experiences with point-of-care testing. And this is specifically for point-of-care STI testing. Do want to make that very clear. Eligibility was defined as individuals with any experience using or prescribing point-of-care tests in a clinical or field setting for the purposes of diagnosing an STI. Participants were approached electronically for voluntary participation, and the study and snowball sampling was used to identify additional respondents. There is a chat that I go slower, so I do apologize for that. Noted. Participants represented diversity of geography, including the eastern, central, southern, and western areas of the US to ensure representativeness. Also, we included clinic and procurement directors, nursing supervisors, as stated, and STI program managers. Next slide, please. So some emergent themes that came up out of this research were, sort of the types of tests that are available, how home testing and how it really came to light in response to the COVID-19 pandemic. I think the field really rapidly innovated around home collect, self-collect testing. Point of care testing opinions and how people felt about it, relationships, insurance, funding, outreach services, HIV care, and COVID-19. Next slide, please. So some pros for clients that emerged from the focus groups, including clients feeling empowered by the immediate knowledge of their diagnoses and feeling sort of really knowing for sure and being able to see the results, and they thought that was a really empowering thing. It was used as an entry point for conversations about counseling, for example, about test results. Some of the quotes here: point of care tests, I think, is so empowering for patients. It's empowering because they know what diagnoses they have, so they can be more secure in the treatment that they're getting because their provider has diagnostic certainty. Another one here: offering an option or several options to a client is good customer service, and it creates opportunity to test based on that client's needs. So again, forming this relationship of trust between the provider and the client in the sexual health clinic setting. Next slide, please. Pros for providers. So participants discussed the difficulty with retaining vulnerable populations within their systems for regular follow-up, including people experiencing homelessness, sex workers, and injection drug users. Additionally, testing that required lab processing time beyond the visit precluded an immediate diagnosis and treatment. So people were worried about loss to follow-up, transportation concerns, et cetera. Testing capable of producing a result with the patient on site is seen as invaluable for ensuring accurate and timely treatment initiation. Next slide, please. So some cons that came up for providers and clients when it came to point of care testing is tests that produce binary results. So qualitative tests were widely seen as not being able to provide the necessary granularity for an accurate diagnosis, and they were considered inferior to tests, in terms of quantitative tests, right? So PCR is gold standard. We think that that's exceptional, but there are some challenges with, okay, I get this test, we can maybe trust results, maybe not, but then we have to do confirmatory testing. So it's really a waste of everyone's resources, right? And so that's some of the information that came up. Again, participants noted that certain point of care tests required the second gold standard confirmatory test, which was difficult, labor intensive, and resource intensive. Also, poor sensitivity and specificity, as well as test readability, were noted as primary reasons a patient would have to go in for an undesirable second reading, having to get someone to come back in if they're even able to do so. Next slide, please. So something that came up that was really interesting is funding challenges, right? So we heard from health departments about the complexities surrounding, managing the various funding streams that they have to manage. In particular, usually providers are not the same individuals tasked with making financial decisions about the programs and managing the financial component. And so it's really challenging to kind of piece all of these different parts together. So clients who were the recipients of either state, federal, or private funding, which often mandated the nature and use of funding for types of point of care tests offered, like, can we even offer this? Is this, allowable under our funding? The management of these sources of funding and the various donor requirements was seen as having significant influence on the provision of these services and the adoption of any point of care test. And the specific parameters for use for these funding sources included participation in the approval processes, which again can create difficulties for clinics as they attempt to secure additional funding for the services that they already provide and the priority population needs. Next slide, please. So many participants noted that their clinics couldn't offer all the tests they wanted to because of funding limitations, right? And so you really have to prioritize who is our population, how do we serve as many people as we can? What does this look like? And you kind of have to weigh convenience and, the patient experience versus financially what you are working with, essentially. A majority of participants shared the feeling of being constrained by funders, and some clinics had to apply a great deal of pressure to funding sources to obtain the test that they needed every day, just to conduct their services. And here's a quote that really exemplifies that. In our HIV STD high risk clinic, we have all of these materials, but in our pediatric clinic, we had to beg, borrow, and steal to get NAT rapid testing for STD care. So there's a lot of sort of internal challenges and complexities surrounding funding that really influence clinics' decisions to engage in point of care testing. Next slide, please. Some additional findings. So test features such as turnaround time, complexity, and cost, as well as operational considerations, including who performs the test, were strong barriers to use. Also, the differing roles of point of care testing from the embodied perspective of the patient, clinic, and administrator constitute a confluence of considerations that may substantially influence their use. So it's really trying to piece together the larger picture. And what we're finding is the larger picture is different based on sort of very specific considerations of particular health department clinics and health departments. Additionally, clinics were reluctant to offer new point of care tests if it sustainably impacted their clinic routines, were cost ineffective, and required a CLIA license. So CLIA waive tests were much more attractive to our participants, as well as tests that were cost effective and that fit well into their workflows. If they were able to identify a way where it fit sort of efficiently into their workflow, they were more likely to consider it. Additionally, it was uncommon for any one of these pieces to be considered in isolation. So again, it's this notion of this larger mosaic, this big picture of considerations, cost, workflow, efficiency. What do all these pieces look like? Desires of the patients and the patient population and their needs. There was some heterogeneity in the precise combination of factors that clinics and programs had to contend with as well. Next slide. Challenges around reimbursement, they were not discussed extensively by our study participants, but we know in previous research that is a consideration in terms of reimbursement from insurance, for example. Most of our participants express that their clinics do what they can to keep costs low for patients, including the cost of testing. And while utilizing multiple streams of funding can allow clinics to provide services that are needed by their target population at low cost, managing multiple funding sources, once again, is incredibly complex. And many clinicians avoid involvement in the funding process because of this. And so as such, there's a distinct gap between those that utilize point of care tests and those that manage the funding. And so I think this really has to be a collaborative discussion among the administrators and the providers of a clinic, and really assessing what does this look like for us, and have people kind of understand each other's perspectives in this. Next. So the lack of the patient perspective was a strong limitation in this study. It's certainly an opportunity for future directions. For some clinics, the pandemic was a means to re-energize existing plans to provide services, which involved expedited dialogue with funders. So creating these conversations, it was really helpful. Managing multiple sources of funding, as we know, is a constant challenge for clinics, and reimbursement for testing was not an issue discussed by many working in publicly funded clinics. And it is imperative that developers and regulators work with client and clinician end users to streamline steps toward adoption of point of care tests for faster and more efficient diagnosis of treatment of STIs. So I'm going to now hand it over to my colleagues at NASTAD, Krupa and Angela.
Thank you so much to all our presenters. We have a lot of great questions. We will try to get to as many as we can. I'm going to throw this first question out, and whoever would like to respond, feel free. Patients are often treated empirically for chlamydia and gonorrhea while waiting for lab results. Is it common for the patient to be positive for both? This may be considered overtreatment for one or the other. Are the providers able to de-escalate when they receive negative lab results? How may this overtreatment affect the patient or antimicrobial stewardship?
Well, this is Gary. I guess I could begin the response. To the first, this is a very complicated question. Thank you for that. Gonococcus and chlamydia can occur simultaneously, and in some settings, it's not at all rare. If one empirically treats on the assumption that a person has one or the other or both, it's not possible to de-escalate care in the case of the gonococcus, since that's a single injection and would have been given by the time you found the result. If the patient eventually comes back chlamydia negative, they may be somewhere in that 7-day course of therapy, and they could discontinue at that point. Whenever antibiotics are prescribed unnecessarily, there's a risk of increasing antimicrobial resistance, and therefore empiric treatment for these infections is certainly to be avoided if at all possible, simply on that grounds as well. I would say that you can see that an immediate definitive result at the point of care would avoid the problem that is implied by this question.
Okay. This question has come up a few times. Are you able to talk about the cost of point of care tests for health departments? Services and supplies come to them from the health department lab at no cost, and approximately 50% of patients don't pay for their visits.
Right. I can only speak with respect to the Visby test and simply say that the cost of the Visby test is dependent in part on the expected volume of the test use in a particular clinic, and whether the clinic is willing to provide a contract for a certain period of time. The longer the contract, the less expensive the test. But in a more broader arena, we're very aware that cost is an important consideration. And to that end, we have automated, or in the process of automating, the manufacturing of this device, which will significantly reduce the cost of the device to all clinics, including publicly funded municipal and county STD clinics. In addition, we're working with the federal government to look at mechanisms for reimbursement for the cost of point of care devices to publicly funded clinics in underserved areas as an additional mechanism to further reduce the cost. Just speaking personally, I'm absolutely committed to bring an effective device to publicly funded STD clinics serving underserved populations. It's something I believe strongly in, and we will work with you to find a way to make it happen. We hope that cost alone would not be a reason for you not to use a device that can transform patient care.
Thank you. And Jenny also mentioned in the chat that NCSD is going to be doing a pilot pretty soon. Please do reach out to her if you have any questions about that or would like more information. The next question is, how many tests can be run during the 30 minutes on one machine?
Okay, I saw that question, and I should have clarified that. There is no machine. So there is no limit to how many you can run at the same time. These are single-use devices about the size of a, maybe smaller even than a cell phone. And after a device is used, it's put in a biohazard bag, and it's either disposed of or it can be recycled. So if you have 10 patients all coming at the same time, you just run 10 of these. You just line them up on a table. They're very small, and you plug each one in to like a power strip, and you can run them all simultaneously. There is no limit to how many can be run at the same time, and we've actually demonstrated this in the COVID version of this device. For example, we screened everybody at the National Press Club who came in. We've screened people at the U.S. gymnastics Olympic team, all at the same time. So I'm sorry I didn't make that clear initially.
Thank you. There's a few questions about reporting, curious about reporting of positive results to state and local health departments. Do any of the studies you mentioned or others touch on reporting processes for point of care tests?
Yes, that's a very important question. I was glad to see that. The current device has a visual readout, and that therefore the laboratory, not the laboratory, but the clinic that uses the device would need to record that result and then deploy that result through the usual mechanisms to the state and federal surveillance officers, as is currently the case. In the near future, the result will be digitized, and that reporting process will be automatic, so that it will not require hands-on efforts by the clinic.
Thank you. Rebekah, how much time do you think we have? Maybe one or two more questions?
Yeah, I would say one or two more. I'm going to push back on you, Gary, because there's a lot of pushback in the Q&A. People would like to know the initial device cost, recognizing that obviously the cost per test will depend on the number performed, but people would like an estimated or average range of costs. And it's been asked by multiple people. So I'm going to throw it back out there.
I know that they would like some specific figure, but trust me that it is a moving target, and any figure I would give would be misleading and out of date. So I'm going to push back and simply say we will work with you to do our level best to make this affordable. And I will also say that it will be increasingly affordable in significant ways as we move forward and the manufacturing is automated. So I'm sorry, but I will not be pinned down because it wouldn't be accurate.
Good answer. Some other questions that are in here, Krupa, since I was unmuted, I just figured I'd grab some. There was a question about the rate of invalid or inconclusive results, if you have data on that, Gary.
Yes, the invalid results currently are running around 2 to 4%, meaning that 2 to 4 tests out of 100 would give a clearly invalid, saying that the test did not run satisfactorily. And there's very clear visual readouts that indicate that there was an invalid result, in which case the result would need to be run again. And there's enough sample in the buffer to run it again. As the automation process takes on and it's no longer manufactured by hand, that invalid rate will probably drop to around 1 to 1.5%.
And then one final question that I see in here, this could be to any of the studies that were done, whether or not there was any looking into the use of this test in mobile units or other, if any of the studies looked at the use in a non-traditional clinical setting.
Yeah, we haven't done that yet, but we are talking about such studies with a number of investigators who in fact are have those mobile vans, one of them in the Birmingham, Alabama area, and the other in Rhode Island in the Providence area. We're very interested in doing that, particularly as it affects underserved populations.
Excellent. Okay, we're at 2, so that is going to bring us to the end of our webinar. I really appreciate all of our presenters for joining us today. I appreciate my colleague organizations at NASTAD and NCSD in co-hosting this. I think this is just a testament to the fact that we should be doing more of these because we serve our members well, and it's nice to have all of us together in one place. So I hope that we will continue this effort. And I really appreciate Visby coming on to present and talk about their new test. And this was recorded, so we'll be posting the recording and the slides so that folks can refer back. And feel free to reach out if you have any other additional questions. Thanks so much. Bye.